Hey, this is Dr. Ben Weitz, host of the Rational Wellness Podcast. I talk to the leading health and nutrition experts and researchers in the field to bring you the latest in cutting-edge health information. Subscribe to the Rational Wellness Podcast for weekly updates. And to learn more, check out my website, drweitz.com. Thanks for joining me, and let's jump into the podcast. Hello, Rational Wellness Podcasters. Today, we'll be speaking with Dr. Dipti Sagar about gastroesophageal reflux disorder, which is a very common gastrointestinal condition. Heartburn is the main symptom in reflux and is often described as a discomfort or a burning pain felt in the chest or throat. It occurs at least once a week in about 30% of Americans, and up to 2/3 of those with irritable bowel syndrome. Heartburn can be caused by a reflux of the gastrointestinal contents up into the throat or esophagus, or it can occur without reflux. Gastroesophageal reflux means that the stomach contents have moved up into the esophagus, and this can damage the esophageal lining, especially if there is acid or bile, and this eventually can increase the risk of esophageal cancer. Other symptoms of reflux, besides heartburn, include regurgitation, chronic cough, sore throat, vomiting, hoarseness, chronic throat clearing. Dr. Dipti Sagar is an integrative gastroenterologist, and I would say one of the few in the country who practices in Century City as an associate of Dr. Sam Rabar. And reflux is one of the many conditions that she treats regularly. So, Dr. Sagar, thank you so much for joining us.
It's been a pleasure. Thank you so much for having me. And for the lovely introduction, I would say you made my presentation very easy because you summarized it so well.
So maybe we can start by defining some terms.
Sure.
So what is reflux? What is GERD or gastroesophageal reflux? And what is heartburn? And sometimes they're used interchangeably. Let's make sure we know what we're talking about.
Yeah, that's great because a lot of times we use GERD for acid reflux and reflux for heartburn, right? So let's make it very simple. Reflux is simply the fact that the stomach contents are moving up into your esophagus. That's simply reflux, right? Heartburn is the symptom that happens because of this. It could be a burning sensation in the chest or in the throat. GERD, which is gastroesophageal reflux disease, is when that reflux happens frequently or causes complications like esophagitis or stricture or Barrett's esophagus.
Okay. Isn't a small amount of reflux normal? And usually this doesn't even create symptoms, right?
Absolutely. It's very normal to have occasional small reflux episodes, and they're asymptomatic. The reason why we don't have symptoms is because our esophagus have protective mechanism. For example, the saliva that we produce. So we produce like 1.2 liters of saliva every day. And what stimulates saliva production is reflux. So every time there is acid in the lower esophageal, in the lower part of the esophagus, which is like 20 centimeters, it stimulates production of saliva. So that protects you. The second is the bicarb, which is again a protective mechanism, and the clearance mechanism of the esophagus, which is the peristalsis, that itself helps to neutralize the small amount of acids that comes up into the esophagus. It becomes good when the balance tips towards injury or towards symptoms. So you're right, a small amount is normal, but we have in our ability to clear it by ourselves.
Right. And essentially it's when the lower esophageal sphincter opens, which happens every time you eat. And once it's open, a little bit of the contents moving up is part of the normal balance, right?
Right. So I'm glad that you brought this. So whenever we are swallowing, it's always associated with peristalsis. So as you mentioned, when we're eating, the lower esophageal sphincter relaxes, it opens, But remember, it's always followed by peristalsis, so that clears the acid. But there is something called transient relaxation of the lower esophageal sphincter, which is different from the regular swallow-induced relaxation, because that one, first of all, is longer. It's more than 10 seconds. It's not followed by peristalsis. So that's different. And in people who have reflux disease, the transient relaxation of the lower esophageal sphincter and motility is probably what causes it.
Right. So essentially, it's a motility disorder, but
Correct.
yet the main treatment is using acid blocking medications like Prilosec, for example, which is a proton pump inhibitor, also known as omeprazole, that decreases the hydrochloric acid. But this is not treating the cause. It's not affecting motility.
That is exactly correct. And the irony is, like, you won't hear this from a gastroenterologist, but I have to say it out loud that most acid reflux patients who have GERD, they usually have normal acid. And this is something that I see in my practice like every day, because when I do an endoscopy, what I do is I collect the gastric juice and check the pH for all patients. And this is not regularly done by a gastroenterologist when they're doing the endoscopy. I have seen so many times patients with acid reflux and they are on omeprazole and they say, I have heard heartburn and I just have so much of acid reflux. I just did an endoscopy yesterday on this patient for acid reflux. And when I did the pH testing, it was actually 2. So the normal pH of our stomach, of the gastric juice, is 0 to 1. So if it's 2, that's like hypochlorhydria, right? Like it's not too much acid. So the main issue is the dysfunction, as we mentioned, about the lower esophageal sphincter and impaired motility. What PPI does, it reduces the acid so it can relieve some of the symptoms, but they don't fix the underlying motility disorder. And the reason why they are the main first line of treatment is because they're effective for short-term relief, but they do not address the underlying cause, the underlying issue of it. And that's why I'm not in a favor of like giving PPIs to patient. Now, in the short term, when you have esophagitis or complications from acid reflux, yes, you can give it for like 8 weeks, but long-term use really don't have any benefit.
In fact, couldn't it harm because it's going to decrease the ability of us to break down our food? We need that hydrochloric acid to break down our proteins and other components in the food. And so if the patient has normal or even decreased hydrochloric acid secretion, and now we're decreasing it even more, and if you're not properly digesting your food, and unfortunately, this is fairly common in our society, partially because everybody's eating so quickly, they're eating on the run, they're eating foods that they can hold in their hand in the car while they're at their computer at work, et cetera, et cetera. And people often don't chew enough. They're not getting enough hydrochloric acid and digestive enzymes to break down the food. So now decreasing that hydrochloric acid may actually make the situation worse.
Absolutely. And I actually can talk on this topic for hours, and that's why I didn't bring it up. But the thing is, we need acid, right? Like there is a reason why there is acid in our stomach, right? So first of all, it helps with the absorption of food. As you said, if you don't have enough acid, there will be malabsorption. Second of all, acid is important for absorption of minerals and vitamins like vitamin B12, zinc, magnesium, vitamin D, calcium. So if you don't have enough acid, you will be deficient in all these micronutrients. Other important thing is the acid in your stomach is actually protecting you from the bad bacteria in the gut. So if you have low acid, some of those bacteria will escape because there is not enough acid to kill them. And that changes your gut microbiome as well. And as you know, like the more we learn about the gut microbiome, we know that all disease actually arises from the microbiome. So just by decreasing the acid in your stomach, you're setting yourself up for malabsorption, disease, inflammation, and chronic conditions.
Including small intestinal bacterial overgrowth, which is something that can lead to GERD.
Exactly. So that is a big thing that people miss. we talk about motility. So the motility, I'm not just talking about the lower esophageal sphincter, but there are two other concepts with motility. First is delayed gastric emptying, which is delay in the passing of the food and contents of the stomach into the duodenum. So if you have delayed gastric emptying, again, which is a motility problem, can cause acid reflux. The other one, which I'm passionate about, I want to bring more awareness, is the duodenal gastric reflux, which is basically the contents move from your stomach to your small bowel. So that's the direction of flow. But when you have dysbiosis in your small intestine, like just you mentioned, small intestinal bacterial overgrowth or fungal overgrowth or any kind of dysbiosis, even parasites, it causes increased intra-abdominal pressure. So now there is backflow of contents or bile from the duodenum into the stomach. So it's like opposite. And this is a very important concept because, as I mentioned, this person I did an endoscopy on yesterday, they had a gastric pH of 2. But you know what was more interesting? Like as soon as I went into the stomach, as a gastroenterologist, you're supposed to see clear gastric juice because the gastric juice is clear. There is no color to it. But what I saw was just yellow bile in the stomach. So there is no reason for you to have bile in your stomach. So why is bile coming in your stomach? It should be going down, right? Like it's a downward flow. That is a clear indication that it's a duodenal gastric reflux. That means bile is coming into your small bowel. And when that happens, remember there is dilution. So the gastric acid, which has a pH of 0 to 1, is now diluted with bile. And probably that's why the pH is now 2. So again, this causes malabsorption. And I would say this happens because of what is in simple language is a dirty gut environment. So whenever there is dysbiosis in your small bowel because of parasites or fungus or bacteria, this is what causes the backflow of bile. So yeah.
So instead of prescribing PPIs, do you ever actually recommend hydrochloric acid and or digestive enzymes and or herbal bitters to improve digestion?
Very good question. So everything should be evidence-based. So in patients, you have already confirmed that they have a hypochlorhydria. Like when I do the pH testing, like this guy who had a pH of 2, then yes, you could gently support them with betaine HCl.
So when you do your endoscopy, you take a sample of the juice from the stomach and then you measure the pH in it?
Yes, that's exactly it.
Now there's another test that I understand is not being done that I think that you were doing previously, the Heidelberg test. What's the status on that? I understand they might be bringing it back in a different form or...
Yeah, unfortunately, we don't have those pills anymore. I think we just have like 2 of them left. They stopped making it. They can measure the acid, but it's not available, unfortunately.
So I think they're going to bring it back in a slightly different form.
Yeah. So, but we don't have that available now.
Right. Okay.
Coming. So in the meantime, we could do the pH impedance testing or any patients who are undergoing endoscopy. It's very easy. You just suction the juice and the pH testing strips is available on Amazon, so like anybody can get it. Like, last week they ran out of it. So I bought it from Amazon for only like $10. And it just...
So this is one of the reasons why doing an upper endoscopy is an important part of a workup for patients with reflux.
That's one part. So checking the pH, but also important to see if there is any mucosal damage, because then the treatment is different. So when I do an endoscopy for acid reflux and I see esophagitis and Barrett's, then the treatment is different because then I know that they would respond to an acid medicine like PPI. However, majority of the patients...
By the way, for those who don't know, Barrett's esophagus means there's a certain amount of damage to the esophageal mucosal cells.
Yeah, so it's intestinal metaplasia, which shouldn't be in the esophagus. So the mucosa in the esophagus changes to that of the stomach, which is abnormal. So that's what Barrett's esophagus is.
Right.
So yeah, to answer your question, you have to look at the mucosal damage, to look at if there is no mucosal damage, is there bile in the stomach? If there is gastritis, all of that information is helpful in deciding how you will manage this patient. So yes, definitely. And in our practice, we do something very special called duodenal aspiration. which is not done in any other endoscopy center. So what is that? Basically, when I go in, like in this patient, when I see there is a problem with the bile, we go in the small bowel and we just suction the bile, which is in the small bowel, and then brush the mucosa of the small bowel and send that for pathology, just like GI map or culture. That gives us information as to what kind of dysbiosis is this. Because if there is a proximal dysbiosis, a lot of time that's not picked up in the breath test. And you'll be surprised that the breath test is normal, but the patient is having all these symptoms, which is very, very, very specific for SIBO. So it picks up proximal dysbiosis, like from Klebsiella, strep, pseudomonas. So if you see all that in the bile, then you would know that this is a proximal dysbiosis. Also, candida is a big issue.
And by the way, one of the advantages of this is then you can treat the SIBO or you can treat the candida, and then that will help to improve the underlying cause of the reflux.
Exactly, rather than having them on PPI for life. That's correct.
PPIs, if you look at the description inside the containers, say that they should only be used for short periods of time. And yet, as you said, some patients are on them for years and for life. So when you get a patient who's on PPIs and you decide that it's not helping them, it's difficult to get them off, correct? How do you get them off?
Very good question. So first, you can give them instructions, but I think that here's where motivational interviewing comes into picture, and we as physicians have this role to kind of talk to our patients. Exactly as you mentioned, it's so much easier to buy a fast food burger and eat it while you're driving, and then just go home and take a PPI. That does not involve, that does not require any change from your side, right? It's so much easier. So if you now tell the patients that you have to sit with your food and chew your food, it takes a lot of effort on their end. So instead of saying like you have to do this, we as physicians should be very efficient in motivational interviewing. And that's where we have to kind of like really tell them, lifestyle is important. Like when we are eating the food, we have to chew the food at least 15 times, like from the front of the mouth, because we are producing saliva. And saliva has important enzymes like amylase, which is so important for digestion of protein. Okay. And also, when you're eating your food and chewing it slowly, you are increasing your mind, gut-brain connection, right? The mind-body connection, and you're like really being present with the food. That really helps. Not drinking cold water, when you're eating your food is also important, because when you drink cold water, you're shutting down the blood circulation, because cold water is going to do vasoconstriction. So there will be decreased blood circulation in your stomach. And that's not very helpful for digestion of your food. You need more blood. So drinking warm water really helps. And obviously at nighttime, don't eat or drink 2 to 4 hours before bedtime. And many times people say that, have my dinner at 6 and I go to bed at 10 and I don't eat anything. But in between that period, between 6 to 10, they're drinking tea, they're drinking this, they're drinking that. So we also have to let them know that even a sip of water can stimulate the acid. So no eating or drinking even water for at least 2 to 3 hours before bedtime. Those are some important lifestyle changes that, we have to incorporate. And also, of course, as you know, a lot of food will relax the lower esophageal sphincter. So we have to avoid those food items. And some food items
and let me just point out also that one of the reasons why people tend to drink a lot of water when they eat is because they're not chewing properly. So the food won't go down. If it's properly chewed and it's broken down into, the proper consistency, then you don't need water to swallow it. But when you're trying to swallow the food whole because you've only chewed it once or twice, then you need a lot more water.
I think you're making a great point there, because a lot of time, when we do, as a gastroenterologist, we do the endoscopy and people come with like stuck steak in their throat. Like, how did that steak get in your throat? Like, it's because we don't chew,
Right.
So I always say, hey, chew your food. We are meant to chew your food and like really not swallow it. So you made an excellent point. And in terms of like decreasing, how do I taper them off the PPI? So I don't take it off immediately. And this is something that we all need to understand. If you are on PPI and if you just stop it, it means that you are going to have a rebound hypergastremia, because all of a sudden you're taking away the medication that has stopped the acid production. So your heartburn and acid reflux will worsen. So what I usually do,
because when you decrease the hydrochloric acid secretion, the body secretes more gastrin that tells the stomach to make more hydrochloric acid. So then when you stop the PPI, you've got all this gastrin and you get this big increase in acid production.
Yeah. And then the patient will be like, oh my gosh, I feel so worse and I'm going back on the PPI, right?
Right.
So that's why we have to taper it very slowly. So for example, if you're on 40, you would go back on 20 and then to 10 and then every other day. So I taper it over the course of like 2 to 4 weeks rather than just stopping it all of a sudden.
Right. I've also heard doctors use a different acid medication on an interim basis.
Yes.
A non-PPI, say.
Yeah, so we can use something like H2 blockers in the interim.
Right.
Along with the lifestyle changes I talked about, stress management, we can
Right.
also combine some herbs, which is helpful for acid for acid reflux, which is DGL or aloe vera or marshmallow, and you can kind of bridge that until you're completely off the acid medicine.
Right. What do you think are the most effective herbs? I know some people have talked about using slippery elm. I've actually had some of the patients make kind of a paste out of slippery elm and use it to sort of coat their throat.
Yeah, slippery elm is great. My favorite is DGL.
Okay.
Slippery elm, sometimes I use in combination, DGL and slippery elm. Aloe vera is another one, but be careful with aloe vera because it's a bit of an irritant. So it can give you diarrhea. So you don't want to have like diarrhea instead of acid reflux. So we have to be careful with that. And then I also like marshmallow and zinc carnosine because they have kind of a very anti-inflammatory effect, especially the zinc carnosine for the gut. So that
What do you
helps.
think about melatonin? I've seen some papers on melatonin having a beneficial effect.
Yeah, I definitely use that too, especially if there is with issues with sleep and usually in combination therapy in a very low dose, like 3 milligram, that helps as well. Yeah.
Okay. So let's see. There's certain foods that we need to consider them not eating that can increase reflux, and that's because they can, say, decrease the pressure on the lower esophageal sphincter, or because they decrease motility.
Mhm. Yes. So anything that decreases your lower esophageal sphincter pressure will increase the reflux. This include chocolate, peppermint, fatty food, alcohol, carbonated beverages, even medications, which are commonly used for high blood pressure, like calcium channel blockers. A lot of patients are on benzodiazepine, NSAIDs, SRIs. So knowing these will allow our patients to make targeted lifestyle changes. Remember, peppermint is used a lot of times for IBS, but it also
Is enteric-coated
yeah.
peppermint oil.
Yeah, but be careful because a lot of times that will relax the lower esophageal sphincter, and now you are dealing with the acid reflux problem. So remove that, the first thing. So important to look at the herbs too, like what the patients are taking. If you're taking a lot of peppermint, we have to stop that.
Now, in terms of motility, we talk a lot of times when we're talking about gut problems about the motility of the intestines and the migrating motor complex, and then we have prokinetic agents that we know work to improve that motility. But the motility of the esophagus is different. What do we know about promoting motility of the esophagus?
Good question. So as I said, every time that there is acid in your stomach, there is peristalsis. So there's motility. But what you could also help with, which I didn't mention before, how we can use saliva for this, like for removing the acid, because that's like a normal alkaline solution, right? So after your meals, what I recommend is chewing some kind of gum. And that doesn't have to be like a sugar coated gum because, as you know, a sugar will have its own issue. So we could use like a xylitol based gum. And when you chew that for 10 minutes after your meals, what's happening? So after your meal, the stomach is full of acid, and some of it might be coming up. If the motility of the esophagus is not very good, or if there is some problem with dysfunction. So when you chew this gum, it's producing the saliva, and the pH of that saliva is between 6.8 to 7.4. And when you swallow that saliva, it neutralizes the acid in your stomach. So it's your body's natural anti-acid without the use of PPI. So if you have a motility problem where there is a delayed gastric emptying or esophagus is not clearing very well, chewing the gum after every meal, like breakfast, lunch, and dinner, does so much good. Like it's like your own natural anti-acid, as I said.
Now, do we know if any of the, say, prokinetic, either drugs like prucalopride or nutritional supplements like we use ginger and artichoke and 5-HTP and things like that, do we and then we have strategies like trying to stimulate the vagal nerve? Do we know if those strategies work for esophagus motility?
Absolutely, it does. Because the stress management is important. So remember, for the anti-reflux, the body's natural way to prevent reflux is three layers to it. First is the pre-epithelial factors, and that is like saliva, mucus, bicarb. And then the epithelial factors, which is the tissue resistance, the epithelial cells resistance. And then there is the post-epithelial factors, which is improved blood flow. Now, that improved blood flow is decreased when you have inflammation, and that inflammation could be from stress. So whenever we work through stress management, decreasing the cortisol, that in turn will decrease inflammation, that in turn will improve blood circulation. So it definitely works.
Okay. I've really been enjoying this discussion, but I just want to take a few minutes to tell you about a product that I'm very excited about. Imagine a device that can help you manage stress, improve your sleep, and boost your focus, all without any effort on your part. The Apollo Wearable is designed to do just that. Created by neuroscientists and physicians, this innovative device uses gentle vibrations to activate your parasympathetic nervous system, helping you feel calmer, more focused, and better rested. Among the compelling reasons to use the Apollo Wearable are that users experience a 40% reduction in stress and anxiety. Patients feel that they can sleep. Their sleep improves up to additional 30 minutes of sleep per night. It helps you to boost your focus and concentration, and it's scientifically backed. And the best part is you can get all these benefits with a special $40 discount by using the promo code Weitz, WEITZ, my last name, at checkout to enjoy these savings. So go to Apollo Neuro and use the promo code Weitz today. And now back to our discussion. H. pylori is a bacteria that grows in the stomach, and this can sometimes be a player in GERD. What should we think about H. pylori? Should we test for H. pylori regularly? Should we eradicate it? I think conventional gastroenterology, my understanding is if you see H. pylori, you definitely need to get rid of it no matter what. But yet there's some controversy over what tests are even accurate for H. pylori, whether stool testing that shows DNA of H. pylori or whether there's stool antigen or a breath test. And then there's an argument that H. pylori is actually protective. It seems to be potentially correlated with decreased esophageal cancer. There's an argument to be made that this is a microbe that is important and we shouldn't get rid of it, even though most of us don't have it anymore. What should we think about H. pylori?
Very good. That's a very important topic to discuss because it's a little complicated. So, just to make it simpler in terms of anatomy and the physiology of how H. pylori works, is that so H. pylori could be in your antrum, which is the distal part of your stomach, or it could be like in the fundus, which is the upper part of your stomach. So, when you have H. pylori, which is antral predominant, and it's gonna actually and you remove it, then it's going to improve the acid reflux. But a lot of time the H. pylori has migrated to the fundus and the proximal side, and if you actually and that is actually protective against esophageal cancer, and if you try to remove it, it's actually going to make the acid reflux even worse. So the best way to kind of do this is when you're doing the endoscopy, I take different biopsies, one in the antrum and then one in the fundus. So if there is an antrally predominant H. pylori, I know that the acid reflux will improve after this. But if it's more fundus, then I do tell the patient that, hey, we can treat it, but it can bring back acid reflux. Now, if you don't have acid reflux, then you can go ahead and treat it, but we have to educate the patients that, it can make your acid reflux worse. Now, in terms of treatment, and I understand what you're saying. So I take a very individualized approach. If
By the way, what do you tend to use for diagnosis? What testing do you think is most helpful?
Good question. So if they're
Accurate.
doing an endoscopy, biopsy is great. But if not, then either the stool antigen testing or the urea breath test, both of them checks for the antigen. There are some problems with that, like, if they have been on antibiotics or PPI or, like red meat, that all of that can affect the way the H. pylori will show up. The antibody testing is not a very sensitive testing because it's a blood test. If you have ever had an H. pylori, even if it's not active, it will come back positive. The most sensitive is the biopsy because it's not affected with all of these. And you can also know like where in the stomach the H. pylori
What
is.
about the stool DNA testing?
Yeah, good, very good. So that one, like especially if you do the integrative labs, the stool testing like GI map or through Vibrant, the problem is those it has to benefit and disadvantage. The benefit is it will tell you the virulence factor, which is very helpful. And the problem is that the titer is not very sensitive because it's going to pick up other type species of Helicobacter, which are not H. pylori. So if I see that the titers are very high, but the virulence factor is negative, and patient is young and has no family history of gastric cancer and have no symptoms which is specific for H. pylori, I tend not to treat it because I think the treatment has more harm than any benefits. Giving them antibiotics is not very good.
What about using a natural treatment, say like mastic gum?
Yeah, I was coming to that. A lot of time, the esophageal cancer that we are concerned about, and sorry, the stomach cancer, is because of the bacterial load. That means the more the bacteria there is, the higher chance of having the cancer. So antibiotic will completely eradicate it, but it has its own complication. But natural therapies like mastic gum, they reduce the bacterial load without total eradication. And that really helps with preventing the complication as well as help with symptoms. But as I said, the decision has to be very individualized based on family history, patient preference, patient's cofactors, all of that.
Right. That's interesting. Now, it's been my thought. I've asked a number of gastroenterologists, and they've all said, "Oh no, the natural treatments don't work. You have to use the quadruple, and now it's a quadruple antibiotic therapy." So and those of us who study the microbiome know that using broad spectrum antibiotics, especially multiple ones, is putting the microbiome at risk, and would rather not do that.
Yeah, let
So
me ask you
that's
a question. So, if you treat a patient with quadruple antibiotics, how many of them come back again after a month or so, or maybe 6 months with again H. pylori positive?
right.
Right? So
Yep.
that's a problem. And I agree that the natural therapies are not very good with eradication, but they are very good in decreasing your bacterial load, and that's all you need.
Yeah, and I've seen that consistently in a number of my patients. So that's why I was kind of skeptical about hearing that they don't do anything, because I think you're right. They're looking at, you haven't completely eradicated it, so you haven't done anything, but it's more a question of the balance, which it is for so many things.
Right. And as you know, how does H. pylori transmit? It's fecal-oral route, right? So if somebody has H. pylori in the house, right, and you give them antibiotics, I'm sure the people who are sharing the plate, sharing bathroom, living in the same household, it's cross-contamination. And that's why a lot of times it's difficult to eradicate, especially in endemic areas, because everybody in the family has it. So you have to give antibiotics at the same time for everyone, and it may work for somebody, may not work for someone else. So it's tricky. So we have to find that balance, as you're saying, the least side effect and the most effective. And I think natural therapy is the way to go.
Now, one category of patients that I've run into several times is patients who have hypermobility syndrome, like Ehlers-Danlos syndrome. And these patients often have other gut problems like SIBO. And because of this hypermobility, meaning their ligaments are kind of loose, these are people who are like hyper flexible, their arm hyperextends, etc. So, which means that some of the connections in their gut, like the valves, tend not to be as tight. And same thing with the lower esophageal sphincter, as well as some of the other valves. Have you run across these patients? I'm sure you have. And are there some strategies that can help?
Absolutely. So the simple answer is the way it works in patients with EDS or Ehlers-Danlos syndrome is that everything is hypermobile, right? So there is a weakened lower esophageal sphincter tone. So we have to understand the physiopathology first, then we do the treatment. So they have the tone of the lower esophageal sphincter is weakened, and that's why they have this issue. So I would do the same things that I talked about, how to clear the acid from the esophagus if you have a lower esophagus. So it's all about lifestyle, chewing your food, saliva production after eating, not drinking water, avoiding the food or medication that's going to lower the sphincter tone even more. A combination of all this natural supplements like DGL. So it's more like a teamwork, working with the patient to see what works, what not. But that's what I do usually in these cases.
Oh, you know what? Now it occurs to me, melatonin, one of its benefits, not related to sleep, is it seems to increase the protective factors in the mucosa.
Right. So yes, that is correct. The other herbs that you could use, which helps with that, it is sodium alginate. That also helps
Right,
with protective thing, melatonin. And then I am also a big fan of artichoke and ginger because they are like pro-motility. So those are some of the
right.
herbs that we can use in combination.
Okay. Now, one category of drugs that really tends to sometimes damage the esophagus are the osteoporosis drugs, the bisphosphonates like Fosamax. Can you
Mhm.
talk about these and what can we do about this?
Yes, so they work differently. The bisphosphonate, they cause direct mucosal damage. So it's not about the motility, it's just that they go and stick with the mucosa and they create ulcers and damage. So because again, if you understand the pathology, you would understand the treatment. So the treatment is simple. Do not let them stick to the esophagus. That means whenever you're drinking or having a pill, which is bisphosphonate, drink a lot of water, like a whole glass of water, so that it goes into your stomach. And then you have to stay upright for like 30 to 60 minutes. Because if you lie down again, it might come back in your esophagus. So understanding pathology helps with treatment. So it's a direct mucosal injury, and you prevent it by not causing direct contact with the mucosa by drinking a lot of water.
Have you ever had the patient do the heel drop thing? You have them drink all
Oh,
this water and then they drop down, and the idea is it kind of pulls the stomach down.
yeah. So don't do that together. So the heel drop works very well. I really recommend, but you have to do it correctly. So you have to kind of lift up and then drop suddenly. And
Right,
people do it just one or two times, but no, you have to do it like 10 times. And I
right,
would say at least 2 to 3 times in the day.
right.
Yeah.
Um, and uh, right now in this country, the most popular new drugs are the weight loss drugs, the GLP-1 agonist drugs. And these drugs work by slowing down GI motility. Are you starting to see an increase in patients with reflux because of these medications?
Yes, and I'm glad you asked this question because I
By the way, these are drugs that we've all heard about that everybody's taken for weight loss that started out as diabetes drugs.
that is correct. And a lot of people are using it. It's funny you say that because I launched my online platform and I do like live sessions in it like every couple of weeks. And this last Friday, I had this gentleman who took GLP-1 for diabetes and now they're dealing with acid reflux and constipation. So I talk about natural ways to kind of lose weight and these things in my platform. So we had like a 2 hour discussion on this. So I'm passionate about this. So first of all, we have to understand that losing weight is not the same as being healthy. You can lose weight by just drinking water or eating like a little bit of chicken throughout the day, but does that mean that you're healthy? The answer is no, because it has a lot of biochemicals that comes into play. With the GLP-1, how does they help you lose weight? They decrease your motility, right? So you're not feeling that hungry, but that in turn also changes your gut microbiome. So we have to understand that concept as well. Um, so to answer your question, yes, a lot of patients with GLP-1 will have acid reflux. The problem happens that we don't take those things into consideration before starting. So I think it's important to have that dialogue with our patients that, hey, this is going to decrease your motility. So it can worsen your acid reflux. It can worsen your constipation. And also it is not a magic pill because once you come off it, you are going to gain all that weight back.
Right,
So are you willing to be dependent on a chemical for all your life? Because ultimately you have to change your lifestyle to
right,
sustain the weight loss.
right.
So
And
that,
and these drugs like Ozempic is one of the most popular ones. You're right. People tend to gain the weight back. Not only that, but there's a tendency when people lose weight to lose muscle, which means your metabolic rate is slowed, and it's going to be even harder to keep the weight off.
yes. And remember, once you are overweight, the chemicals in our body alters in such a way that your mind and body will try to maintain that weight. So you have to remember this because that's why it's easy to lose weight, but maintain it is difficult because now you're kind of fighting against all these chemicals. So training how to kind of reduce that fight, and then setting a new baseline for chemicals for your system is more important. And that's the way to sustain the weight loss rather than through the help of these chemicals.
You've talked about some specific foods like coffee and mint to avoid, but is there a sort of general diet that's beneficial?
Very good question. Nutrition, I love that because I think food is medicine. For acid reflux, I would say that a whole food based anti inflammatory diet with emphasis on mindful eating, as we mentioned, chewing the food thoroughly, having smaller portions throughout the day, and avoiding those trigger is key. There has been some benefit of low FODMAP diet or low acid approaches. And if somebody is interested, they could look into that. But I believe in adding more food items rather than removing. So eating everything, but more like whole foods, non-processed, that's the way to go.
What about food allergies
Good question. So yes, food
or
sensitivity.
food sensitivities? Yeah.
Yeah, so the food sensitivities can trigger inflammation and motility changes, and that can worsen your acid reflux. So, if you have been tested for food allergies, and if you are allergic or sensitive to something, you could start with an elimination diet. But as I said, in my practice, I have seen that it's never the food which is the problem. Because if you do the food allergy testing on a person who has a lot of GI issues, they will come back positive for like 50 different food items. But it's usually not the food, it's because there is something going on in your gut, like there is a dysbiosis or there is a leaky gut, which is causing all these allergies. So that needs to be addressed.
Right. Some patients with gut problems have histamine intolerance or elevated histamine levels. Can this also be a factor?
Absolutely. So high histamine levels from diet or from mast cell activation or poor breakdown of histamine can increase the acid secretion, and it can also worsen the reflux. So you have to support the histamine metabolism and reduce the food items that has histamine. And I also feel like it's kind of a vicious cycle, because if you have dysbiosis, gut issues, then the histamine is produced every time you eat the food. So rather than just suppressing the histamine, addressing the root causes of why you have elevated histamine is also important.
Okay. I think those are the main questions that I had. Any other things you want to tell us about?
Yeah, I think in patients with acid reflux, a lot of time we just think about the digestive tract, right? The stomach,
Right.
esophagus. But you have to understand that if the traditional approaches have not worked out, then we have to have a more multidisciplinary approach. And what I'm really talking about is that sometimes acid reflux can give you atypical symptoms like bad dreams or headaches or sinusitis. And when you have a patient who has not improved with conventional treatment, we have to look beyond the digestive tract. And things like oral cavity. So if you have infection in your mouth because of root canal or poor dental hygiene, remember the microbiome in your oral cavity is not separate from that in the gut. It's all
Right.
connected. Swallow that. So you have to look in your oral cavity and probably refer them to a holistic dentist who can actually clear up the infection in the mouth so that they can have a better microbiome. And sometimes that helps with acid reflux.
Right. I understand if you have, say, an increase in P. gingivalis in the oral cavity, that'll lead to a more acidic pH in the mouth.
Yes, exactly. That's absolutely true. The other thing that we miss is I had a patient actually who had very refractory acid reflux, and she was losing weight, and then she had IBS, and we did all these endoscopies and different testing. Ultimately, I referred her to an ENT specialist, and what she really had was a deviated nasal septum, and she went under the surgery to kind of correct the septum, and her acid reflux improved. So looking at the sinuses to see if there is infection there, because they're all interconnected. So just to keep in the back of the mind that sometimes it's really not the stomach or the esophagus, but it could be the sinuses, it could be your oral cavity. So we have to have like this whole person approach to this.
Yeah, that's a really good point. And I think the oral cavity can play a role in almost any GI condition, including it could be a factor in IBS, SIBO, and dysbiosis, and we often don't really pay much attention to it, and we really need to.
Yes, we do. And I think we don't ask this question to our patients, but we should ask them like at night, do you breathe from your nose or from your mouth? This is
Right.
such an important question that we miss as physicians, primary care doctors, because if they're breathing from their mouth, then it's kind of like just changing your microbiome, not just in the mouth, but also in the gut. And really, the answer is very simple. You just tape your mouth so that you breathe from your nose. Obviously, your nostrils need to be clear, but this is from habit. Some people breathe from the mouth, and that can affect your gut health also. So please start asking this question to your patients going forward.
And address your oral hygiene with flossing. Do you like things like oil pulling?
Well, I feel like if your sinuses and nostrils need to be open, and
Okay.
whatever helps with that. I'm a big believer in breath work and meditation.
Okay.
I teach a lot of that in my platform as well. So there is something called alom vilom, which is kind of a breath work where you close one of your nostril and you breathe in from this one, and then you close this one and breathe out from the other one. That's if you do that practice every day, it will help to open up your sinuses and nostrils. So simple things. You don't really have to go to ENT. If you can just do this and open up your nostrils, that would be very helpful.
That's great.
Yeah.
So how can listeners and viewers find out more about you, get in contact with you, your website, etc.?
Yeah. So that's the QR code. You just like
Okay.
do this, and that will take you directly to my online platform. And yeah, once you join, you'll have access to self-paced modules, gut health, root cause, all of that. I do live Q&A sessions. We did one session with how to remove subconscious blocks for healing. Doing the live Q&A sessions, it's so much fun. It's a sense of community. A lot of patients are there and we support each other for
Now,
healing.
not everybody is going to be looking at this. If you're listening on your phone, you can go to my Weitz Chiro YouTube page and you can pull this up. And this will be towards the end. Or if they just want to type in your URL code to go to your website, where would they go? Would they use this code here?
Yes, you can use your phone to kind of scan this. If not, the URL is on the top, so we can just put that.
You want to read it out real quick?
Yes,
So yeah,
sure. So it's www.skool.com, and then there is like a
/
slash and Gutwana. So GUTVANA / ABOUT. And also, if you guys follow me on Instagram, I have this link on the Instagram. So that's another way to kind of get the link.
What's your Instagram handle?
It's Dr. Dipti Sagar. That's it.
That's great.
Yeah, it's all together. There are no dashes, all smalls. Yeah.
Thank you, Dr. Segar.
Thank you so much, Dr. Weitz. It was such a pleasure.
Thank you for making it all the way through this episode of the Rational Wellness Podcast. For those of you who enjoy listening to the Rational Wellness Podcast, I would very much appreciate it if you could go to Apple Podcasts or Spotify and give us a 5-star ratings and review. As you may know, I continue to accept a limited number of new patients per month for functional medicine. If you would like help overcoming a gut or other chronic health condition and want to prevent chronic problems and want to promote longevity, please call my Santa Monica Weitz Sports Chiropractic and Nutrition office at 310-395-3111, and we can set you up for a consultation for functional medicine. And I will talk to everybody next week.